The advancement flap is drawn so that the length is approximately 2.5 to 3 times longer than the width. Care is taken to stay in the subcutaneous plane during the excision of the lesion. Countertraction is helpful during incision and excision. The scissors can be used to undermine as well as to cut the deep layers of the soft tissues. The skin incisions themselves should be made with a sharp knife. Care is taken to incise perpendicular to the skin edges. Again, the entire flap is undermined in a layer between the skin and the deeper subcutaneous tissues. Undermining is continued beyond the extent of the dissection by 1 to 2 centimeters in all directions. This allows for easier flap mobility. The first suture is placed in the center of the flap and out the central aspect of the defect. This is tied with a hand tie and a surgeon's knot to prevent slipping of the knot. By keeping constant tension on the sutures, one can prevent tying an air knot. The suture is cut with a small tail that prevents unwinding of the suture material over time. The corner sutures are placed next, since they are the other primary sites of tension in this flap design. Here an instrument tie is being utilized for the corner stitch. Again, a surgeon's knot is put down on the first throw, and now we have a problem of unequal skin edge length. The skin edge is longer than the flap edge. We will then close this with the principles of halving. The first or central suture is placed in the middle of the inferior edge of the flap and in the middle of the corresponding skin flap. The two halves on either side are still uneven, but less so. Subsequent sutures are then placed so that it splits the difference between the previous sutures until enough sutures are placed for adequate closure. In this way, the redundant skin of the lower flap is spread evenly across the entire wound closure and results in a smooth wound edge. On the upper flap, we have closed it so that the skin is closed in an even manner, resulting in a standing cone deformity at the inferior aspect of the flap. The standing cone deformity excision is always done away from the flap pedicle. A single hook is placed in the dog ear, and the triangle that is formed can easily be seen. It is then marked with a surgical marking pen. An incision is made perpendicular to the skin edge so that we can mark out the point of a triangle. Undermining is done under this dog ear deformity. The skin is transposed back until one can exactly see how much skin is needed to be trimmed. The skin is then trimmed and the flap is inset. This flap is then sutured into place and the dog ear deformity is resolved. Here we can see a circular lesion that's now being excised. We can see also the first flap is already marked, and that's approximately 3/4 to full diameter of the circular lesion to be removed. And you can also see the second flap, which is approximately 1/2 to 3/4 of the diameter of the lesion. And the angles are approximately 45 to 50 degrees along the long axis of the flap. Here you can see the lesion has been excised, and now the limbs of the second flap are being incised. The first flap is now being incised, and that's more circular because that needs to be rotated into the area of the defect. Now a triangular portion is being removed as the remainder of the first flap is being undermined. The reason the angle or triangle needs to be removed at the apex of the first lesion is so that that first flap can be rotated into position. We're undermining the second flap now, actually wide undermining, either with scissors or 15 blade is necessary to allow the rotation. Again, wide undermining The triangle to be removed is also undermined, and the area of the lesion is now being undermined. The triangle is now being excised so that the first flap, as it's rotated into the wound, is not overlapping skin. Now that first suture can be placed at the apex of the flap, or it can be placed here at the peak and the valley of the flap. The order again is not as critical as accurate placement, and here we can see the closure of this apex and valley so that the first flap can be rotated into position. Usually we use a two-handed tie for placing the first sutures in points of tension. Here's the suture being placed at the apex of this first flap, and that is being sewn into position. And now we can begin to see the flaps being rotated into position. Here we can see the second flap that's being rotated into position. That's being closed. If there is a excess at the tip of this flap because of the apex, that can be trimmed off. Another suture is being placed here to close the area of the second flap, the donor region of the second flap. And we can begin to see how the wound is coming together. We use the remainder of the sutures to be placed according to the principles of halving. If any dog ears occur, again, we remove a dog ear by placing a hook at the apex of the dog ear or standing cone, and then use a back cut away from the flap and trim that tissue to allow the flap to be closed. Here we see the circular lesion removed and the first and second flap in position. The fusiform excision is marked with a length of 1.5 to 3 times the width. The intervening skin and soft tissue is then excised. The incision made in the skin edge should be perpendicular to that skin edge. The fusiform to be excised can then be removed with sharp dissection using either knife or scissor. The skin to be excised can be held with a forceps or a skin hook. The middle finger can also be used to aid in the retraction of the soft tissue during the dissection. In order to allow the tissues to come together during the closure, undermining is necessary. When scissor dissection is used, the tips of the scissors are best kept tip upwards towards the skin edge so that the deep structures are not inadvertently cut. A number 15 blade can also be used to continue the undermining. This demonstrates that either a scissor or a number 15 blade can be used to undermine the soft tissues, which will allow closure without tension. The first suture that is placed is a deep suture, and it is buried. It is placed in the dermis at approximately the mid portion of the incision, according to the principles of halving. A surgeon's knot is used to close the deep tissues, thereby approximating the wound edges. Notice how the wound edges come together. The deep suture is cut on the knot, and the wound edges are now well approximated. A second deep suture is placed according to the principles of halving.